Okay. So I did prepare, a bunch of slides about assessment, but if there are burning questions about assessment, I just kind of guessed what people want to know about based on when families call us and have questions about the process. I've had so many of these conversations over the years that I can anticipate some of the questions, but not all of them. So feel free, I don't know the best way, maybe through the chat. If there's something that I'm not covering or you want me to stop on,
Yeah, what people can do is put your questions in the chat, and just so it doesn't go crazy, I'll interrupt Lindsey. Lindsey, I'll interrupt you and let you know if there's something burning on people's mind. And then if there's some logical places to take a break, we can do that as well. So I'll let you determine the flow. But if everybody could submit their questions via the chat until we're done with the presentation, that'll allow Lindsey to get through as efficiently as possible.
Sure, but also feel free, because one of the things I've learned since the pandemic presenting this way is sometimes it's hard for me to read how people are responding, and if they, when it's in person, I can kind of like feel out the audience, but it's harder like this. So I don't want to go on and on without addressing questions. So feel free to let me know. But thank you, Judy, for the introduction. As she mentioned, I've gotten to meet with this group a couple of times before, and it's always really just a fun, warm group, I think, to meet with. I'll tell you a little bit about our clinic toward the end, but I am the founder and director of the Sterling Institute for Autism. We are in Long Beach, kind of bordering Seal Beach. So we see a lot of families from Orange County, Los Angeles, and actually all over California, because we're licensed to see clients all through California. So with the introduction of telehealth, that has helped us reach a further, even more families. I always like to give a little intro so that you know kind of my background and where I am coming from. So I'm not just making all this stuff up, even though sometimes it feels like that. So I'm a Southern California native, went to UCLA for undergrad and studied psychobiology, and then went to University of Washington, where I got my PhD in child clinical psychology. And I went there with the intention of specializing in autism. So when you apply to these programs, you apply to a lab with a mentor. And so I knew going into graduate school that I wanted to do all of my research, my dissertation, everything in autism. And then I came back to UCLA for, it's really a residency. We matched somewhere. So I went there for a year and then did my postdoc there, was on clinical faculty there, had the opportunity to go to Claremont McKenna College for a year, where I was an interim professor and directed the autism center there. Then went to Cal State Long Beach, was on faculty there before really moving to private practice full-time. So I come from this academia research-based background, which is different than some clinical psychologists, but that's the track that I went through. I grew my practice a little over a year ago because if some of you overheard maybe Judy and I talking, there was such a long wait list. For therapy, we do therapy, but especially for evaluations, families in some cases are waiting a year, 2 years. And that just didn't feel right. And so I've grown so that there are a few of us in our group who are specialized and qualified to do these evaluations. We'll talk about maybe toward the end when we talk about cost, that unfortunately that doesn't provide access to all families, because it's an expensive process. It's a specialized process. And so if you can't pay out of pocket, a lot of people still are waiting for insurance-based evaluations. And that can take many months or even years to get an evaluation. So the system is broken in that way. And we're not necessarily doing a great job addressing it, but we're trying little by little. Here are some of the questions that I came up with. And like I said, if you have more, then feel free to jump in. Who can get assessed? Sometimes we see a lot of teens and adults, and sometimes people don't realize that they can get a diagnosis later in life. And who can do the diagnosing? So we'll talk about that. And then, of course, what happens during an autism assessment? What can you expect? How long does it take? Where do you do this? Like, who do you call? How do you do it? The why, and this is the questions I get a lot from parents. Sometimes I get this from one parent. So I'll be doing an intake and maybe one parent kind of drove the assessment and sought it out, and the other parent is sitting in the intake going, why are we doing this? So we have this conversation a lot. And then of course the cost. What can you expect going into this? So like I said, these are the questions I came up with. But if there are more that I don't address as I go through, feel free to let me know.
And Mary, I'm Lindsay. I think these are really good questions. I think you've hit it on the nose to a large degree.
Okay.
I guess one other thing that if you can touch on at the end might be, once you get a diagnosis, what should you do? So just maybe that might be something useful at the end. Yeah.
Okay. That's a great question. Okay, so we'll just jump in with who can get assessed and who does the assessing. And the short answer is anyone. So I would say the youngest we've seen in our clinic is like 15, 16 months. We like to wait a little bit longer than that. There's data to show that the diagnosis is more stable after the age of 2, but there are some cases, we'll do some screenings over the phone to get a sense of what the parents' concerns are. And if they are salient enough, we'll see them that young. Our clinic, so we see 16-month-olds, 2-year-olds, 4-year-olds. I would say what's different about our group is that we tend to get a lot of referrals for older kids, teens, and adults. And so all through grad school, a lot of my training was in little kids. I'm a child psychologist, but a lot of my research was actually with adults, autistic adults. And so as part of my training, I actually saw lots and lots of adults too. So this has always been kind of like a passion of mine to see some older folks too. And by older, I mean not the 3-year-olds necessarily, right? But older kids, teens, and adults. I'm gonna make sure I'm going in the right order now. Okay. Some of the reasons that I get when people call, and these aren't real quotes, these are like over the years, if I had to summarize some of the quotes that I've heard, one of them is the really obvious, like a pediatrician sent me, right? So the pediatrician suggested that I get an assessment, or teachers have been suggesting it, or a school psych said that there are some signs that came up in an IEP and we wanted to get an official diagnosis. A very common one, a very common story, I would say, is I was diagnosed with ADHD and anxiety and whatever else when I was younger. Sorry, I'm hearing my little one outside. And some of that fit for me, but it didn't seem to explain everything. So that's a very common sort of statement that we get. Or it seemed to explain things for a little while, but when life got harder or more complicated, it didn't really cover it for me. So I want to know if there's something more to the story. Another one might be, I've always felt a little different. A friend, a teacher, a therapist, whoever suggested maybe looking into autism. And once I started reading about it, a lot of it fit. Of course, we get lots of parents calling for kids saying things like, my child is really bright and does well in school, but struggles socially. Another sort of common thing is I always sensed that something was different. I just thought of him, or I just thought of myself as being quirky. I get a lot of parents or teens themselves who feel like there's been a regression in adolescence. And it's not a regression 99% of the time, but it's that being a teenager is really hard anyway. There's lots of hormones, lots of emotions, lots of changes. And so it's when we see the rise of lots of psychopathology. It's also when expectations increase for kids. And so if they've been kind of sliding by using the strategies that they have, sometimes it doesn't quite cut it when they become a teenager. And so sometimes that discrepancy between themselves and their peers starts to become more obvious. Social interactions become more complicated. All of those things happen in adolescence. And so this is often a time when parents become concerned and when they seek an assessment. I'll go through the diagnostic criteria for autism too. That was one of the questions. And then I get a lot of teens who say like they're the ones who drove the diagnosis or the assessment because they want help explaining what it is that they're struggling with, and they think this might help explain it. So this does not cover all the reasons why people seek an assessment. Of course, there's the more run-of-the-mill, like younger kid who's maybe delayed in speech, and the pediatrician, wants to rule out autism. But I would say for the older kids, teens, and adults, these are a lot of the questions or the statements that we get. Who does the assessing? So there's some folks that I don't know out there, they're clinical psychologists. So the Autism Diagnostic Observation Schedule, or the ADOS, which I'll tell you a little bit about, is considered the gold standard for an autism assessment and diagnosis. And it takes lots of training, and it can take months, years to get the training, apart from getting a degree. So this is like learning the actual assessment, practicing videotape. Back in my day in grad school, we had VHS tapes. We would videotape ourselves doing the ADOS, send it in to have, the trainers review it. We would go to Michigan where these assessments were developed and practice and be observed and practice scoring. And so it tends to be someone with an advanced degree who does that. And to my knowledge, unless there's other folks out there, these are clinical psychologists who do that. It is kind of confusing and overwhelming for parents. Even friends who have known me forever and know my training, they still get confused about this. Pediatricians can't technically do these unless they're a developmental pediatrician with specialized training, and there are a few out there. The majority of pediatricians can screen using a checklist. There's like one called the MCHAT, for example, that they'll give young kids. And it's a good place to start, but a pediatrician should be able to tell you if you should see a specialist. If you think about all of the things that pediatricians have to specialize in, from a broken leg to RSV to COVID to autism, right? They're not necessarily experts in autism. I think that's getting better. But when I was in graduate school, I had like 3 hours, really like 2 hours, to train the pediatric residents that would come through the clinic. And I would talk as fast as I could and teach them everything about autism, and then they would leave. And we were doing this for 6 years. They had like 2 hours. Like I said, I think this is changing because there's so many more folks with autism out there. But it can be a little bit hit or miss. School psychs are different than clinical psychologists. They have master's degrees and they have testing experience, but they can't actually provide a medical diagnosis like for insurance purposes. They determine if a child meets eligibility for services at school. And oftentimes they have a really good sense of whether a child is autistic, but they can't actually do an official diagnosis. So we often get parents who say, on the IEP, he qualifies as eligibility as autism, but he's never been officially diagnosed. And they'll come to us for that assessment. Every once in a while, a neurologist will give a diagnosis. And I see the next question. Every once in a while, a neurologist, and I don't want to say too much about that. Sometimes I see like a half-page note from a neurologist about an assessment. It's not necessarily a thorough assessment. It doesn't mean they're wrong. They often get the diagnosis right, but it's not the same as a thorough psychological eval. I kind of mentioned schools. Psychiatrists often have a really good sense. I get great referrals from psychiatrists to do evals, but again, they don't do the eval themselves. And then same with speech therapists, OTs, behavior therapists, they're interventionists. And oftentimes they also have a really good sense and will provide referrals. There was a great question about, what causes autism? And that honestly would be like an entirely different talk. We could talk for hours. The very short answer is that we think it's a neurobiological condition, meaning it's the interaction between genes and environment. And so oftentimes there's a genetic predisposition. We think there's many genes involved in autism. And so sometimes in family members, it's like there's a sprinkling of genes, but they don't meet full criteria. And maybe a certain combination causes that in children. But there's no it's not a result of bad parenting. It's not a result of even drugs. Drugs can have a big, like in utero use of drugs, for example, can have a big effect on child development. And many of those kids have autism, but it doesn't cause autism per se. So happy to talk more about that. But like I said, that's a big topic to go through. But thank you for the question. Okay, what happens during an autism assessment? We usually start with an intake. And an intake is sort of like a psychiatric intake that you might do with a psychiatrist. It's more general in nature. It's not necessarily specific to autism, because we'll get to that next. But the style that we have, and this is different for everyone, the style is different for everyone. So in our clinic, I can speak for how we do it. It's a little bit different than, let's say, at a university, which is a little bit, because I used to work at universities. It's much more formulaic at a university, and there are pros and cons to both of those things. So it's not that one is better, it's really what's better for you and your family. In a private practice, we have the luxury of being really flexible and tailoring the assessment. So when we do an intake, we really talk about what the person's goals are for the assessment so that we can tailor it for them. This collaborative style means that it's not me just holding a secret clipboard and taking notes and doing a grand reveal at the end. It means we're having a conversation all the way through the assessment so that the people, like the families involved, right? Like, you know your child, you know yourself the best. It's my job to help you take all of this information and make sense of it, and your experiences and your concerns, and make sense of it. But it's not for me to like hold this secret and then reveal it at the end. It's really something that we do together. And I want to make sure that my impressions make sense to you or whoever I'm doing the assessment with. So we ask things like, what questions will you want answered by the time the assessment is over, right? This way we can make sure everyone is on the same page and we're clear about everybody's expectations for the assessment. We often ask, who's the audience for the report? And we'll get to this when we talk about adult evals. These are different than kid evals. A child evaluation oftentimes has to be very official, right? We want to make sure that a child qualifies for services, that they get support at school and accommodations. So we often write these like 20-page comprehensive reports. An adult might need that. Maybe they're in college. They might not, right? The audience might be just themselves. They might just want like a 3 or 4 page letter summarizing our impressions. So this is really important. This helps us guide the assessment and the data that we collect during the assessment. We ask, do you have any secret questions? Because sometimes there are other reasons people are coming for the assessment, or secret concerns like, oh my gosh, there's this great uncle in our family, and this is really my secret concern is that this is, trickling down to my son. What is it that, you're really worried about? Like, let's try to be honest here so that I can really try to address this the best way possible. We also ask, well, what outcome would be the most disappointing for you? Like, is there something that you don't want to hear at the end of this, or information I could provide to you where you would be like, oh my gosh, this was a waste of my money, right? Like, we want to make sure that we're really catering to what we're here for you, to answer questions for you. And that's our agenda. So in the intake, we really go through the plan for the assessment. And then we go through things like family history and medical history and academic history and what you might expect in an intake. Sometimes people ask, well, what do I get at the end of this, right? And I don't want to stereotype it. Often, like I said, it's one parent driving the assessment and the other one going, what, I'm spending money, like, what do I get, right? And that's a fair question. I don't want anyone to go into the assessment not feeling like they get something out of it. Sometimes what they get out of it is this report, right, that they have forever to document how they or their child are doing, and it helps them qualify for services. But really, the diagnostic process itself, I always tell parents and I tell adults going through the process, it should feel therapeutic in and of itself. The process itself is important. It's not just the outcome. The diagnostic process should make people feel validated and heard and understood. help family members understand each other and get on the same page. Oftentimes I do the intake, and like I said, let's just say hypothetically speaking, it's the dad who's like, why are we doing this? This is a lot of money. I don't think it's autism. I can relate to a lot of this when I was a kid and I'm fine. By the time I do the feedback, even if I'm not meeting with the dad repeatedly, there's something about the process itself. I'm always kind of like preparing myself to convince the dad, for example, right? Or to like talk them through. Oftentimes they get to the feedback and they're like, yeah, I'm good. Over the last month, like I've been researching this a lot. I've watched my son go through this process, and it's helped get the family on the same page. So that's when I feel that it's been a good assessment. It's not just the outcome and the bottom line, it's the process that should feel good for people as they go through it. Someone asked the diagnostic criteria for autism. I actually show this to families. Like I said, I have a very
Lindsey,
Yeah.
there was one question before you do that, and you may be getting to it later, but someone wanted to know what's a recommended age to do the evaluation. I thought that was a good question before you.
Yeah, so there's no right age, right? So if you have a young child and you're concerned about their development or they're delayed, then that's a good time to do it. If you have a 12-year-old and you've always wondered and suddenly life is getting hard for them, that's a good time to do it. If you're 45 and you've always wondered about autism and you're struggling in your job because job politics are confusing and relationships are hard and you want the question answered, that's a good time to do it, right? So it really depends on the person and where they're at in life. Most of your adult children already have a diagnosis. Do you have any adult resources available like OT? What's SNL? Speech and language, maybe?
Do you want to do that at the end when we discuss what should you do once you get a diagnosis? Because I think at that point, that might be a good time to veer off into treatment. Thank you.
Sure. Okay. So someone asked the diagnostic criteria for autism. I just want to make sure that I had that right. Yeah. So I'm not going to spend too long on this because I also am going to kind of assume that a lot of you might know this. And so, oh, do you want me to do this later too, or you meant the other question, Judy?
I meant the other question about therapy.
Okay.
Yeah, no, go ahead.
Okay. No, that's fine. Let me know. And also I realize the chat doesn't always pop up unless I move my arrow up there. So if I miss something, just let me know. So I go over this with families again, because it's collaborative and I want them to know what it is that I'm looking for and looking at and trying to make sense of as we go through the process. So I tell them that as I'm interviewing them, as I look at data from questionnaires, as I interact with you or observe you or your child, I'm trying to figure out if it fits on this or if there's a better way to explain what's going on. And so there are two main, like I said, I'm not going to go into too much detail, but really, I think if this is how I see it in my head, there's like two main parts of autism. The first part is social communication and social interaction, which is really language and communication used for social purposes, to connect with people, to connect emotionally, to have back and forthness, relationships that go two ways. The second half of autism is this mishmash that we call RRBs, restricted repetitive patterns of behaviors and interests. And so the way that I was trained, and I was just talking to a colleague about this today, that this is sort of changing over the years, but we were always trained that this blue circle, social communication, is the core part of autism. And this other stuff, you only need a couple of those to meet criteria, but it's not always that clear. And I won't go into too much detail, but I think now that we see more subtle cases, we're really trying to understand this social piece at a greater, deeper level. But this purple area, the RRBs, has to do really with repetitive behavior, things that people do over and over again, or in specific ways, ritualistic behavior. In here, we have intense interest and sensory sensitivity. I always tell parents when I go through this, we call these symptoms because we're beholden to the Diagnostic and Statistical Manual, the DSM. And to make a medical diagnosis, we have to, we have to note symptoms, but these are not all negative things, right? Having an intense interest and a passion is a wonderful thing. Having Insistence on sameness. Sometimes we see kids or adults with this wonderful conviction and this sense of like right and wrong, right? Used in the right way, some of these things are really positive things. And we have a strength-based, neurodiversity-based approach to our assessments and all of our work. And that's part of the work that we do with parents during the assessment, is to help them understand that their child's differences, not just what's wrong, but what's different. And sometimes those are good things too. Always happy to come back to that slide. I'm gonna go through this quickly. The point of these slides is just to let you know that during the assessment, we're not just going through yes, no autism. We have to consider the big picture, because we don't want to just go in with these like goggles that we're only seeing autism, right? Because we have a sense to do that when we specialize in something, we become biased and we see everything through that lens. So the theme, I'm not going to go through all this. The gist of this is that in psychiatry, in psychology, symptoms overlap. We're people, right? We're not just a box of symptoms. And where we draw this line, what do we call anxiety and what do we call depression, for example? It's a little bit arbitrary. It's based on research, it's based on experience, it's based on response to medication and treatment. But we are just kind of like drawing this line and saying, well, this is depression and this is anxiety. But you can see there's a lot of overlap, right? The same is true for autism and anxiety, for example. So when you think about that second circle, the purple circle with ritualistic behavior, insistence on sameness, when we're anxious, like I'm kind of an anxious person. I like to know what to expect. I like predictability, right? Like, where do you draw the line and say, oh, well, this is autism and this is anxiety? So this is part of our job when we do an assessment, is to really try to dig deep to understand the etiology or where behaviors come from, right? So when somebody says, I don't like social interaction, we're trying to understand, does that come from being anxious and avoiding social interaction so you get less experience with it and then you feel like you're not good at it? Or does that come from an inherent maybe challenge with some of those social situations? Yeah, there's a few slides that I didn't include in the handout. I added them after, but I'll catch up to the ones that are in the handout. Okay. This is just a picture I put in a lot of presentations where it's like just showing how arbitrary where it is that we draw the line with some of these symptoms. Okay. When we do the assessment, and I apologize if this is like redundant for some people, because if you have gone through a diagnostic process and you already know this, but there's two main parts to an assessment. One is developmental history, and the other is interacting with the person. Developmental history to me is almost more important, and this is always surprising. I'm looking at the question, does OCD overlap with autism? Yes. And ADHD? Yes. Just to make the picture more complicated, and I can speak to that more if we have more time, but those are we're often teasing apart those symptoms and often co-diagnosing if it makes sense to. And that's a great question. So remind me, whoever asked that, if we have time at the end, I'm happy to come back to it. The reason why developmental history is so important, and I always tell parents this, I tell teenagers this, you don't catch autism when you're 15. You don't catch autism when you're 25. But it might be that life became more stressful and expectations became greater. And so some of the aspects of autism that maybe were masked or weren't so apparent become more apparent or get in the way more as people get older. And that's when they seek an assessment. But we have to make sure that the way I describe it is like a thread that you can pull through from early childhood, right? You have to establish that there's a history. So I do the autism diagnostic interview, which is kind of an old school, like I was trained on this interview 20 something years ago, but I depend on it. It takes like an hour and a half or 2 hours to go through it with a parent. And they're always surprised. Sometimes they're like, you're only meeting my child once, or you're meeting them twice. And it's like, yes, because the history tells the story. And when we meet someone, it's a snapshot in time, right? It's helpful and it's important, but the history to me is really where I can dig deep and try to understand how some of these differences that we're seeing at 15, at 20, at 30, where they came from and when they started. So some people skip over this. I don't know. I would not feel confident doing an assessment skipping over it, but that's also just my bias because it's how I was trained. But this I do after the intake. So I talked about that general intake that we do. The next is the ADI, and there's like 85 interview questions in the ADI. And I've done this long enough that I've kind of memorized it. And there is a score at the end, but I can kind of tell as I'm going through. I get a sense as I'm going through about symptoms. The second part is what I referred to before, the ADOS. And the ADOS for a young child, for those of you who had children diagnosed, you might remember, this is a play-based assessment. This is what it actually looks like, this tub of toys. And we put a bunch of toys out and we watch how a child plays with the toys. We watch if they social reference, if they look at people and try to involve them, if they play interactively, if they use imaginative play. The ADOS has 4 modules. So after this play-based ADOS, there's module 2, 3, and 4 based on a person's level of speech. So for an adult, I would use a module 4 usually. And instead of having all these toys out, it's much more conversational. I'm asking about emotions, about friends. We also, not to get too into the weeds, there is some pushback about the ADOS, like how valid is it really with an adult? And so most of my colleagues and I who do the ADOS, we do the ADOS, but we incorporate other stuff in it, other questions to make it so that we can go a little bit deeper than just observing someone for like an hour. I'm just looking at the overlapping of symptoms question.
Yeah, that seems a little complicated. We might want to go to that when we, with, other diagnoses and kind of, that might make sense. The Sabag's question to combine it with
These
Janet.
are such good questions.
Yeah.
Yeah. The question, I'm just going to quickly address do they drop the diagnosis when they are younger? There's a lot of controversy about this. So this is a great question. Some people are like, yeah, I would do the assessment again. And if they don't meet criteria, they don't meet criteria. I'm a little bit more in the camp that this is a developmental thing. So you don't erase history. But people learn very good coping mechanisms and strategies, and they do great. I think if you think of autism as a type of neurodiversity and the way that people process and see the world in this really unique, wonderful way, it's not like a diagnosis that you just drop, right? This is kind of how somebody sees the world. Whether that's still like pathological in a negative way, it doesn't have to be, right?
This is a really troubling issue. In that we had Peter Himberg from the regional center speak, and he's a doctor, and he deals with admitting, a criteria for admitting people into the regional center. And so a lot of times, first of all, regional center has a cutoff for either demonstration of being autistic, not necessarily a diagnosis, but that's very confusing. And then second of all, there's so much work that, like, my son went through. He must have done 15 different therapies that helped him along the way, that you don't know whether they would come out with that diagnosis, even though, because the test, he may have learned skills to have him perform differently on the test. However, the personal work and the effort and the who he is and the struggle he is and the reasons why he might need services are still there. So it's a scary thing in terms of the world saying, oh, they're cured, they're fine, they no longer need services, when the underlying issues are still there and could arise in a situation where something bad happens and now they've regressed or something like that. So it's a really tricky issue. And I hope that that it's looked at very seriously before some change is made in that.
That's a great point. Yeah, about being able to qualify for supports and services. And some people, the goal isn't always to like get cured, right? Like, again, if you think of autism as having some amazing strengths and differences and seeing things from a unique perspective, and the fact we think that this is how people's brains are wired, it's not a negative thing to be cured from, right? And so there is debate over even the language that we use around that. Yeah. You know, we're still at the stage where there's no like blood test or biological marker for autism. I've been saying for years, and I still think it's true, that one day, like, I'll be out of a job, right? And there will be a way to do this. There's lots of people are working on this, on finding markers or genetic profiles or whatever it is to try to find a better way of diagnosing. But I do think that there are going to be like 20 or 30 autisms, right? Like, if you think about how different and unique each person is who's on the spectrum, there's got to be a gazillion causes and etiologies. So it's not as simple, even finding like a blood test or a marker. It's not something like Down syndrome where there is a clear connection and cause like that. So it's a complicated job. Okay, let me just make sure I'm not missing anything.
You're
So
not.
do you view autism as a permanent disability? Oh gosh. That's a complicated and somewhat loaded question, right? I don't view it. I don't use the word disability. I try not to use symptoms too much. It's more differences. But it depends on the terminology, the context that you're using, right? So like when Judy's talking about like the regional center, you have to prove that there's a disability to get services, right? But in the rest of the world, I try not to use that term because I think there's some extraordinary things that come with being autism and being autistic. And I have a slide on that too to talk about it. But again, this is it's such a complicated question. You could have like a 5-hour presentation on that with lots of different perspectives. Okay, so what is the actual process? Again, this is my process, and I think most of my colleagues who I know have a similar process, but it might vary depending on who you go see. I mentioned that we do the intake, and then the autism diagnostic interview, and then the ADOS. So we've kind of talked about those first few steps, and this could take a couple of weeks by the time we schedule these appointments throughout the weeks. I'm not going to go into great detail because it can get a bit complicated, but in some cases, we're doing also some cognitive or executive functioning testing. And so this is where if there are questions about ADHD, for example, or someone is really struggling in school and there seems to be more to the story, or an example of when cognitive testing might be interesting is, let's say the parents are like, this kid never engages in conversation, like no chit chat, no conversation. We're like, let's measure his verbal comprehension. Is there something going on there with his actual intellectual ability in terms of verbal comprehension? Would that explain why he's having a hard time with conversation? Maybe it's not autism. Maybe there's an actual verbal difficulty. Or the opposite. Maybe they have a super high verbal comprehension score, and then you're like, oh, this is more of a social difference, right? If they're having a hard time with conversation. I always tell parents, for autism itself, this isn't necessarily required to do more testing. Sometimes it's informative, and sometimes we need it to rule other things out. And so that's a case-by-case basis. In our group, we always talk with collaterals, which means sometimes we do a school observation. Other times we talk to teachers, we talk to whoever referred them. If there was a therapist or a teacher, sometimes I'm calling 4 different people during an evaluation. Today, I talked to someone, I'm evaluating a 16-year-old girl, and I talked to a psychologist who evaluated her 3 years ago for ADHD. I talked to her executive functioning coach. I'm going to talk to her teacher. Obviously her parents, right? If I'm doing an assessment with an adult, I can't always do an autism diagnostic interview, right? So if I'm doing an assessment for a 45-year-old, they might say their parents are out of the picture or they don't want to involve their parents. We find other ways. Somebody shouldn't be, they shouldn't be stopped from getting an assessment or a diagnosis that could help them just because their parents aren't in the picture. So I have gotten really creative with this. I've talked to siblings, I've talked to parents. I did do an assessment with an adult who really had no family around. I always try to find someone who knew them when they were young. She really didn't have anyone. So I ended up talking to a couple of longtime friends, and I asked questions like, what is it like? What was it like when you went out to a bar with them and people came up to talk to you guys? What happened when you introduced them to your boyfriend? You know, what have you seen them go through in terms of relationships? So we get creative and we find other ways to get information from collaterals when we need to. And then the last meeting is called the diagnostic feedback, where we actually go through diagnostic impressions. And like I said, my goal is that when we get to that point, it's not a huge shock to people because we've been having this conversation the whole time. And then after that, we send a report. Where can you get an assessment? So the pandemic has really helped us get creative with this. I went through several months or maybe a year of not doing assessments because I was like, you can't do an assessment without meeting the person. And then we realized that wasn't helping anyone because then people were just sitting and waiting for assessments and diagnoses. So we had to come up with something better than nothing, right? So we got really creative. We would have parents set up PlayStation, like toys and different things for their kids, and we would watch through the camera. The adult ADOS is based so much on conversations and questions that we can do a lot of it over telehealth. We do all of the parent interviews now over telehealth. There's no reason for people to drive into the office to be interviewed. But when we do the ADOS, and sorry, the wording got cut off here, we do our best to get in person and to meet people. We used to do this outside at the park during the height of the pandemic. We would find like a private area. We got so creative during the pandemic, but now we mostly go into the office when we can to get as much interaction as we can with the person. Oh, I didn't put, okay. So the other where that I didn't make a slide for is just, obviously you can come to a private clinic like us. You can also go to a university-based clinic. So like UCLA or UCI, they tend to have more insurance coverage, but longer wait lists. Regional center, my experience, and Judy, maybe some of you have different experiences with this, is hit or miss in terms of who you get to do the testing and the assessment. I always suggest to parents, if they have kids in school, to start with school, get the cognitive testing, do as much as you can to get a foundation, and then we can add on the autism part. It saves them some money.
Some things that I found, Lindsay, one is they'll say we do screening, like they'll have these screening clinics, but we won't necessarily do assessments. So sometimes you get that. And then also sometimes my experience with the school, and it may be different now, was they tended to not want to say that your child had a diagnosis. And so they all know, they're talking in the teacher's lounge about it, but they don't tell the parent. I'm not sure if that's a legal issue or if that's a political issue or what, but then, so they're not necessarily going to be offering to help with the diagnosis, although I suppose you could try and push for it to be in your IEP. But those are some of the tricks out there that seem to throw people.
Yeah, I think that's a great point. I think a lot of people don't feel qualified. So there are people who do full neuropsych assessments or psychological assessments, except autism. And so I work with a few of these amazing psychologists who are so experienced, but when they have concerns about autism, they give that to me and we collaborate. And I think it's the same in schools. It depends on somebody's training and experience. Again, they can't give a medical diagnosis anyway, but yeah, I talk to school psychs about this a lot, educational psychologists, about like the training needs to be different because there's so many kids, right? They need to be able to understand the subtle signs and not just the more obvious cases, but it really depends on their background and training. And it doesn't even just differ from district to district, it differs from school to school, depending on who's there. Let me just see what this question is. Does the regional center accept the identification by the school for autism? I don't think so, because what school does is they say the child meets eligibility. So they're in an eligibility category for school to qualify for certain services, which is different than getting a medical diagnosis. Judy, is that your experience as well?
Yeah, I mean, you're going to need a medical they're going to be investing a lot of money in your child, and, all the way till death do they part. So they're not going to accept anything other than a medical diagnosis. There are the issue with regional center is you're supposed to have demonstrated being autistic before, I believe, the age of 18. And I think you get why is a diagnosis important. You're probably going to get into that. So what they will do, I've seen them do it, I don't know if everybody would be the same, is that if you do have school records that seem to indicate that your child was struggling with autism, even though it wasn't diagnosed, especially there's a lot of people that are older now who it just wasn't a thing.
Well, it's really silly, because the definition of autism, to get a diagnosis, you have to establish, like it's in the DSM, the definition is you have to establish that a child had symptoms early on. It used to say before the age of 3, now it's changed and it said in early childhood, but symptoms may not become fully manifest until there are stressors in life. So even if someone is getting diagnosed at 19, by definition, you can't give a diagnosis unless they have had symptoms early on. So the regional center should know that when they say, like, can you prove that there were symptoms early on? It's like, we wouldn't give a diagnosis if there weren't symptoms early on.
And that's why there are fair hearings.
Yeah. So it's a little bit of it's so hard for families to navigate all of this. It's hard for me, and I've been in the field for so long. I'm just looking because some of these questions are relevant. So will you share what background school psychologists should have? So school psychologists have a master's in psychology. So they don't necessarily, so a master's is 2 or 3 years. My training was like 10 years, right? So there are some absolutely wonderful, my kids, there's like this awesome school psychologist at their school, right? There are these amazing school psychologists, but they're not specialists. Right. So they have a more general training. They can do cognitive testing. They should be able to identify learning differences. They should notice if a child is at risk for autism, ADHD, any of those things. But again, their training might be variable. And so it's hard to know. And there's actually, I won't get on my soapbox too much, but there's actually a lot of debate by the American Psychological Association why we're all called the same thing. Because we have different degrees and different training. And so it's really confusing for people who don't know the difference in terms of what different people can do and what we're qualified to do. How do we check if the person is qualified and legit to do the diagnosis? How do we find them? So it should be a specialist in developmental assessment in autism. So if you look at their website, if you look at their bio, make sure they have experience. I mean, there are people who more and more, because neurodiversity is such a big thing, more and more saying, oh, this person is an expert in autism and OCD. And you read their bio, they have tons of experience in OCD. They now have seen some patients with autism. It doesn't mean they have training in that. So you have to sort of shop around, and you have to be your own advocate. I always tell people when they're like, I tell friends, if you're looking for a therapist, for example, interview them, ask to chat with them for 15 minutes on the phone and ask some of the questions. And you can get a sense, like, do they get it? Right? Like, do they get it when you're talking to them? And if they say they can't chat with you first, then they're not, then don't bother. Because as busy as we are, and we're super busy, and I've got kids of my own, I will always talk. Even if I have to schedule it for next week, I'll find 15 minutes and talk to a family, because this is an investment, not just financially, but emotionally. And you should feel confident in whoever you're seeing. So you can ask those questions. It's not offensive. Like you can ask, do you know this? Do you feel comfortable doing this? And hopefully they'll be honest with you when you ask them.
So I think
Why?
we should do this slide. Why could a diagnosis? Hey, Lindsay, why could a diagnosis be important?
Yeah. So why could it be important? So one is to identify strengths. And this is so important, especially for teens going through this. I never want an assessment to feel like what's wrong with me or what's wrong with my child. I want a diagnosis to help explain maybe what they have been struggling with or explain why they feel different. But it's also to talk about what's really cool about them. So when we do an assessment, let's say I do an assessment for a 16 or 17-year-old, and at the end, I give a feedback to the parents and I write this big like official report. I also meet with the teen and I write them like a 2-page letter, and at least half of the letter is about their strengths, about all of these wonderful strengths that they have. Because this is not, like I said, it's not just about what's wrong with someone. Having autism, being autistic can also mean that you have strengths that other people really don't have. And it's really important to me that this is conveyed in the assessment. Some of the things that come up, and this is based on research too, not just experience, incredible memory for detail, memory for past events, depth of knowledge, right? When someone is has a super intense interest or is passionate about something, you've never met anyone who knows more about that subject, and it's incredible. Intense and passionate interests. Sometimes these are channeled into really productive things. And even when they're not, how interesting, right? That somebody has a passion about something. Many people on the spectrum are very opinionated and have strong conviction, and they stick to what they believe in. They're the most loyal friends and loyal employees, oftentimes, really sticking to the rules at work, wanting to please, being so, and I have this over here, but being so honest and non-judgmental. Like there's never this like idea of manipulation, but really just saying it like it is, right? Which sometimes can rub people the wrong way, but sometimes can be so refreshing. So they can be very dependable friends or employees, this incredible attention to detail. And there's research about this, about the brains of autistic people and how, and there's terminology for this cognitive process. I just gave a talk about this to a learning center, about this idea that an autistic person can pick out the detail in something, oftentimes, or a pattern much quicker than someone else. Some of this is related to strong visual and spatial skills. Another reason sometimes to do cognitive testing, because we pick up on incredible strengths so that when we give feedback and write a report, it's not just what somebody struggles with, but we have data to support also what they're really good at. Such creativity and talent. I'll talk about this at the end, but I just started a girls group for teen girls on the spectrum. And you guys, every single girl, there's like 6 girls, every single one of them is gifted in terms of perfect pitch singing, acting, writing, ballet dancers. I mean, these incredible gifts that these girls have. And sometimes it's because of this intense, passionate interest. And just having this unique perspective that other people don't have, which we need in the world, because it would be super boring if we all saw things the same way. So I won't go into this too, but you can tell I feel strongly about this because I want parents to see this in their kids. I want teens and adults to recognize this in themselves, but also this comes with a very delicate balance of also validating that when you feel different from other people, it's hard. So I try to be very clear when I go through people's strengths that I'm not just sugarcoating what's hard for them too. And especially for teens, they're like, yeah, okay, I have these good things. But, you know, with a teenager, if you're the tallest, the shortest, your hair looks different, anything that's different can be hard. And so if you're neurodivergent and you think in a different way, that's extra hard. So I try to validate that as we go too. I'm just looking at the comments. So yes, our kiddos do have so much potential, and honestly, like, we don't want everybody thinking the same way. That's boring. So it's really important. We really try to celebrate this in our group too. Okay, why else could a diagnosis be important? So the very straightforward one is qualification for services. ABA, you might know, is a bit contentious. Some people come to us because we don't talk about ABA on our website. And I've had moms call and they're like, we picked you because you don't go on and on about ABA. However, there are data to support that ABA can be helpful, especially with behaviors that are really difficult to manage. So we try to have an open mind about what will fit best for each kiddo. The truth of the matter is that to get insurance coverage for ABA, when a family really feels like they need ABA, they need a diagnosis, they need an assessment. It can help them qualify for an IEP, but a school may say that they have to do their own testing to verify. And it can help qualification for regional center, which we talked about. So sometimes this is the motivation. Sometimes parents, for example, already know their child is autistic, and we try to make the assessment much more efficient and just do what we need to qualify for the services. That gets back to like, what are the goals? Yeah.
Let me just add, Social Security, SSI, you need to have the diagnosis as well. You need to have it by age 22. So when they ask when's a good time, you need age 18
That's a great point.
time to have it done by.
Yeah.
And keep it, because you're going to need it if you want to get into some of the disability programs at some of the colleges. You always need to keep your diagnosis handy.
And sometimes college requires it within a certain number of months or years. So you would need a reassessment. But I agree with you. Parents sometimes are like, oh, my child graduated from his IEP. And I'm like, keep it. Like, don't get rid of stuff, because you never know when you might need.
I have binders in my house where I know where that stuff is. And you never know when someone's going to ask you to pull that out. The next benefit that you thought you would just get, you're going to have to show proof again that he has a diagnosis.
Exactly. Yeah. One of my kids is on an IEP for speech articulation, and we've been able to add other accommodations that he's needed. And they keep saying, well, when he graduates from speech, and I'm like, oh no, he needs speech. I'm like, keep him on the IEP as long as we can. So yeah, thank you for adding that. I appreciate it, because there are other services to qualify for. And these are just some examples, by the way, so feel free to chime in if you guys think of others. Oftentimes parents come to us, again, already knowing the diagnosis or suspecting it, but they want to review recommendations, want more thorough testing, so that when we give recommendations, they feel much more specific to their child, or specific to the phase of life that their child is in, right? So maybe they got a diagnosis when they were 3, but they want a reassessment when they're 8 or 9 because the recommendations change. And so that's often, these are just, again, examples of recommendations that we might make. And we really do rewrite them for each child. So this is not a cut and paste. We really go through and try to figure out what would be the most helpful. And sometimes we really don't know until we've done a full assessment. Other times we do brief consultations where people have a diagnosis already, and we'll meet with them and really try to talk through what updated recommendations would be the most helpful. Same thing with accommodations. So when it comes to academic support or even work support, whether it's grade school, high school, college, we try to talk through, again, this isn't just like us coming up with these, but we talk with the family, talk with the young adult or the teen about what they've struggled with, what has been helpful, what would be more helpful in terms of accommodations. Parent insurance beyond the age of 6. Great point.
26.
Thank you. Yeah, 26. Yeah, so that does get back to that question about timing. That's great. Self-understanding, right? So again, some of the reasons for assessment and benefits of assessment are concrete. Some are not. And I talk to parents about this. Some of the reasons are not because of a thing that you get at the end, but it's because like I said earlier, the process itself is therapeutic. There's something about feeling heard, feeling validated. Someone understands me. Someone's trying to explain what I'm going through. Someone is reassuring me that there are other people who have gone through similar things. So much of that is therapeutic. There's research about this collaborative style of assessment that it actually reduces the amount of therapy that people need later on, because the assessment itself can feel so therapeutic. Some of the words that I've had clients use are, feeling like it's a relief. It gives me an explanation and it provides some clarity, because there's been so much confusion over the years, especially for some of these more subtle cases. I talk about this a lot with parents, this idea of a framework. So I have some parents who, rightly so, are concerned about the idea of a label. We never want to label our kids. We don't want to feel like other people only see them as a label, right? And that's a really understandable concern. What I try to talk with parents about is that sometimes we need a framework to better understand our child, or to better understand ourselves. It gives us the context. So a concrete example of this might be, you go to your family's favorite restaurant, for whatever reason it's closed, but there's another restaurant next door that's open, that's pretty good. You've been there before and you can go, and your child melts down, right? You think, what's a way of interpreting that? They're being self-centered, they're being stubborn, they don't care about anyone else in the family, they're so inflexible, right? We have this negative terminology when we don't understand. When we have a framework and we understand, oh, someone's autistic, and actually changing the routine or the expectations actually feels internally distressing and uncomfortable. Oh, okay, this is really hard for them, right? This can build empathy in the family. This is just one random example, but there's thousands of examples like this. I even work with some couples where one adult is neurodivergent or has autism, right? Sometimes simply understanding the context, it doesn't excuse people. It doesn't suddenly make people connect and happy, but it helps us understand each other. And when we understand each other, there are fewer assumptions and negative judgment, right? So providing a framework for the family is really important, especially when it comes to like parents and teens. We've heard so many negative, dads talking about their sons being so rigid, so inflexible, so stubborn, so rude. They won't even say hi to family members, or so rude, right? Then we understand, wait, actually, autism helps explain some of this. And it's like, oh, he's not being rude. He's really uncomfortable and he's struggling. It doesn't mean we totally accommodate, but when we understand, we have more patience and we figure out better strategies to help support them. This isn't just within the family, but this is also for teachers to understand. We often encourage parents or teens or adults themselves to provide teachers or professors with a tip sheet, like getting to know me. How will you know when I'm stressed? What are some accommodations that would be helpful for me? Like, I'm just going to put a card on my desk and walk out the door for 5 minutes. When I'm overwhelmed, I have to do that, right? So that the teacher doesn't think, this student, they don't care. They just leave my class in the middle of a lecture, right? So this context and this framework really helps people understand each other and builds empathy and understanding. I'm sure there are many more reasons, but the sixth reason that I put up here is belongingness. It really helps when people feel like there are other people who can understand their struggle. This goes for parents of neurodivergent kids, and it goes for people on the spectrum themselves. Many of the teens that I see have already found a lot of online groups or support groups and feeling like, oh my gosh, there's other people who kind of speak my language and understand what I'm going through. And sometimes you don't need an official diagnosis for that. In my experience, a lot of the folks I work with, they want that. They want the validation to know like, oh yes, I actually am a part of this group. So again, there are so many more reasons, and I'll probably later tonight be like, oh, I should have mentioned these other 5. But these are, I would say, like the top 6 that come up when I'm working with families. Okay, how much does it cost? To be honest, a lot. So I'll start with that. And I will tell you, as a parent of 2 kids, I sometimes feel like I do this work and like, I can't always afford it for my own kids. The system is kind of broken. I'll just kind of start with that psychologists and mental health professionals in general, we're not reimbursed in the same way that other medical professionals are. Maybe it speaks to the values in our society. So honestly, most of us can't live off of insurance reimbursement, so we don't take insurance. It's a pretty bad system because then we're only selecting really the people who can afford the services, right? So, most of us do private pay. This is kind of a busy slide. So actually, why don't I go back one just so that there's not so many words, and I'll just give you the context. Our clinic and most private psychologists are private pay. The cost will vary. Some psychologists do a package where they say, no matter what the assessment, it's $3,000. Or in Los Angeles, I've heard people say it's $10,000. In our clinic, we do hourly. Mostly, I've played around with this a ton and gone back and forth with it. But we do that so that we can individualize it. So if someone doesn't need as much testing, it's fewer hours. If they need more testing, we give the option and they can add hours. So that's how we do it. But if you go to like a university clinic where insurance might, like half of it might be covered, then it's probably cheaper. Let me go through some of the variables for that. So the scope of the assessment can vary widely, especially for an adult. When a family comes to us, we give them a document depending on age. So young kids, the assessments are very straightforward because there's not a lot of history or complicating factors. So a 3-year-old assessment is actually pretty brief and straightforward, and it's one of the cheaper types of assessments. The older a child or a teen gets, the more complicated it is. We're reviewing their records, we're talking to lots of people, we're trying to make sense of a long history of different diagnoses sometimes, and the testing is more complicated. For an adult, this is actually the most variable. We have adults who are like, I'm in college, I've never had a full assessment, I need accommodations, I want the whole shebang and a 25-page report. That can be, $3,000 or $4,000 by the time you add up all of the hours. Then we have adults who are like, I've been wondering, I've been researching, I'm out of school, I don't need accommodations, but I just want to know. And here's what I can afford. And we try to tweak it and have fewer visits, fewer hours, and kind of do the bare minimum. And instead of writing a 25-page report where we charge a few hours for the writing, we'll do a letter where we charge more like an hour or two for the writing. So for adults, it really varies depending on what their goals are. And we try to talk that through with them before jumping in so that they know what to expect. Most private psychologists like myself, we provide what are called super bills, and you guys might have experience with this. Basically, what this means is you have to pay for the visits as you go. And then at the end, we provide what's like a receipt with the diagnostic codes, the codes for the sessions, and you submit that to insurance with the hope that insurance will reimburse you. And we always suggest to families, if you are going through this process or contemplating going through the process, call your insurance first and ask them what they will cover. If you explain that you need to see a specialist, it's so hard to find anyone in network, for example, who does an adult assessment for autism, then sometimes you have better luck getting reimbursement or coverage, but it does vary depending on your policy. So we don't deal a lot with insurance, but we're always happy to work with families to give super bills and to get them to you quickly so that you can get reimbursement if that's part of the process. There's probably more questions about that. I don't know if nothing has come up, but.
I just wanted to mention a couple other things for younger kids. I think for under 22, I think that the Chalk Autism Center will do diagnosis, as will the UCI Center for Autism, and they do work with insurance. So if that's important to you, Kaiser might have something in network.
That's true.
They work with Easter Seals on autism. So there are are ways that you should check out. But I always recommend Lindsey.
Thank you.
For private.
It's hard, that I always wonder, like, okay, so what would I do with my kid? In a way, I really trust universities. Like my training is all through universities. So the quality is probably pretty good. Like if you go through UCI, UCLA, Chalk. The downside is that it can't always be tailored. Sometimes you have one person doing an intake, one person doing an ADOS, another person doing the feedback. So I sometimes get families who have already gone through those processes being like, we just want one person to follow our kid through the process. The other downside is the wait at a bigger place of months and months or years. I would always say, get yourself on the wait list, right? Like if there's a chance of getting insurance coverage through one of those places, there's no harm in calling and getting on the wait list and seeing how long it takes, right? And then you can always ask around with private psychologists and see what their fees are like. It can be an overwhelming process.
So there's two questions that we kind of put in the parking lot that these would probably be good to talk about right now. One that goes really well with this is age. People are saying, is there an age, an ideal age for getting a diagnosis? So you might want to take that first.
Yeah, so some of them are logistical issues like Judy that you mentioned, which I think are really important, right? About having your child on your insurance or qualifying for Social Security or regional center. So it's important to take those into account. Clinically, so separate from the policies and qualifying for things, I guess a couple of things to note clinically in my experience. Not always, but when someone does not have a diagnosis and does not have accommodations, but they're maybe super bright and capable, sometimes they go away to college and they fall apart that first year. And I've had lots of experience with families kind of dealing with the fallout from that. And so if you have a high schooler and you suspect, I would say get an assessment before college to help get the ball rolling. So that's one age. I used to say my number one referral age was 12-year-old boys. For years, I just kept getting 12-year-old boys. There's something about that age that must be really difficult. Pre-puberty, things are changing.
Well, when they go through puberty, they change a lot. And so behaviors appear that weren't there before. Plus the environment, moving into middle school, you're moving from a very supportive one teacher, one classroom environment to this chaos with physical education. And the combination of all that is just a witch's brew of problems. So
it is. So it's nice before the full-blown teenage years to do that. I can address the MRI question. I saw that too. I'm happy to talk about that in a couple of minutes. But other than that, it's really when, before a big change is a good time, right? So if your child is transitioning from middle school to high school to college, or anytime an adult feels like they've been stuck. I have adults come who have keep struggling in jobs and they don't know why, or relationships, right? So there's no bad time to come, but I would say before big transitions are important. The caveat is that and I don't know, since this is more of an adult group, obviously if somebody has a 2.5, 3-year-old and they're not talking and they're concerned, don't wait, right? That's where early intervention is super important. But if we're talking about older kids, teens, and adults, I would say before big transitions, is a good sort of rule of thumb to go by.
Yeah, I kind of think the earlier the better, Lindsey, because when they're young, I believe in ABA, so there are definitely a lot of therapy. My son, like I said, he had probably 10, 15 different therapies, and those help, you can see the difference between someone who had some therapies, who was less high functioning than others. If someone's really, really bright, you may not know that. But the sooner you get it, you may be able to get on an IEP. The more you demonstrate an ability to do things, the less resources you're going to get.
True.
So and the higher the risk that, and getting a diagnosis isn't really necessarily an easy thing. I mean, having Lindsey around is wonderful. Back in the day, there's plenty of stories of people having 5, 6, 7 diagnoses before they got to.
We still see that. Yeah, we still see that. And I agree. I mean, in my training, it was always early intervention, early detection, early intervention. That was like drilled into us. So absolutely, the sooner the better. I think that, but there are, again, like reassessments. We do a lot of those. My child was assessed when they were 3. When should we do it again? I would say before a big change. That said, I like to reassure parents when it comes to assessment, when it comes to all of the recommendations. Sometimes we'll give 12 recommendations. Nothing is an emergency unless it is, right? So sometimes we feel like as parents, once we suspect something or we feel like we should do something, we should have done it yesterday. It's rare that anything is truly an emergency, but yes, the sooner we can jump on these things, usually the better, right? So if you're concerned about it, it's better to get the clarity and to know what you're working with and what could be most helpful.
So there was a question, I guess you can answer the MRI question, but then I think we might want to talk about treatments, and somebody had some questions on specific treatments.
Sure. So the MRI question, that's a fun question. So the answer is no, unfortunately. There's not an MRI technique to find out if the brain is different. However, there are many caveats to that. I used to do this research in graduate school, so that's why I think it's fun. There are lots of different patterns that we see in autism, but it's pretty specific to aspects of autism that we're studying and not autism as a whole, right? So what I mean by that is there's an area of the brain that's sort of there for emotion processing, right? And we might see that that area of the brain lights up differently, maybe for people on the spectrum, or recognition of faces. We used to do this. This was like a big hot topic of research several years ago, that people on the spectrum didn't recognize other faces as easily. And so we actually saw a part of the brain that would light up in someone who wasn't autistic when they saw familiar faces. And then when someone was autistic, it didn't light up as strongly. But the really cool thing is if they had an area of expertise, their brain would light up when they saw pictures of that. So if they were like an expert in cars, their fusiform gyrus, which is the part of the brain for processing faces, would light up. So there are these really cool studies that look at, brain response to different stimuli, but they're pretty specific, like I said, to different aspects of autism. Now, there was, and I know you're recording this and I don't want to misquote this study, so I'm going to be careful because I haven't read the whole study, but the last international meeting for autism research, IMFAR, the keynote talk was actually about different patterns of brain response. And they looked at people with autism. So, we don't really use the term like high functioning necessarily, right? But if you think about the more subtle cases of autism and people with ADHD and people with more profound autism, right? So maybe the nonverbal folks engaging in repetitive behaviors. When they looked at all of those people together, what they found is that the more subtle cases of autism and ADHD looked more similar, whereas more profound autism looked different. And this gets to this next question about diagnostic overlap, right? And we're learning more and more, and we're seeing more and more of this overlap between ADHD and autism. So now I'm going to kind of get into the next question. When I was trained, like in the early 2000s, we weren't allowed to co-diagnose ADHD and autism. There was sort of this misunderstanding that ADHD was inattention, and in autism, we have hyperattention. So how can we diagnose both of those? As the years went on and they rewrote like a new version of the DSM, people came to realize that in ADHD, there's often dysregulated attention, right? So anyone who knows someone with ADHD knows that actually they do hyperfocus sometimes. It's not just about inattention, right? And so if you think about it that way, you can see how maybe this idea of diagnosing just based on attention doesn't rule out the idea that you can have ADHD and autism. In both ADHD and autism, we have difficulties with executive functioning. In both ADHD and autism, you can have social differences, right? So if you think about someone with ADHD who's maybe impulsive and interrupting and not tracking everything in the conversation, or just trying to be silly all the time when it's a little kid, they can have some negative social consequences also, maybe for different reasons though. So yeah, oftentimes, very often we get like, oh, there was a diagnosis of ADHD. Does that fully explain it? And what we usually do, at least what I do, is I keep the old diagnosis too, unless I really felt like it was wrong, right? Because oftentimes, like, I wasn't there when the child was 9. They were assessed, they were diagnosed with ADHD. ADHD medications are helping. I might add autism in, but I probably won't take away ADHD. OCD is a very interesting one because in OCD, we see some rigidity and ritualistic behavior. There's a lot of research about whether this is similar or different to some of the ritualistic behavior that we see in autism. I'll give you kind of a surface answer that won't cover all of it. And in fact, I'm meeting with an OCD group in about a week to talk about this topic, and I will probably have more information then. But oftentimes in OCD, there are obsessive thoughts about things. That's one aspect of it. And then sometimes a person engages in a compulsive behavior, like I have to do this 3 times or this bad thing will happen. Whereas in autism, there seems to be this sense that doing things in a ritualistic way regulates and calms the person, and they just like things in a certain order. It's not necessarily because of a thought that something bad will happen. So the obsessive thoughts about the thing aren't necessarily there. So again, there's a lot of overlap. You can imagine, I often get a very common referral. I said 12-year-old boys were the most common before. Now I get a lot of teenage girls, and a common referral is they were being treated for OCD, but then the OCD therapist realized they're really suffering socially, and they're wondering if there's something more to the story and if the OCD is really part of autism. So this is really tricky for all of us, not just parents and folks out there, and we work hard to find the most parsimonious explanation. We don't want to give people 5 diagnoses. We want to figure out what is going to explain this with the fewest diagnoses, but with also identifying as many as are needed for intervention, right? So that example of ADHD, I don't want to take that away if the intervention like medication is helpful. I don't want to take an OCD diagnosis away if intervention like exposure and response prevention for OCD is helpful. So it's really tricky. This is why I do those long developmental history interviews, and I try to figure out where these differences or symptoms come from. So that probably doesn't answer all of that, but that just kind of touches on some of the complexities that we deal with during the assessments. Can someone with high functioning ASD be in denial of the diagnosis? If so, how can we best support them? Oh, burnout. Yeah, we haven't really been talked about burnout. So if someone is in denial of the diagnosis, it's sort of similar to some of the parents who are worried about a label. I often wonder if that's because there's a misconception about what autism is, right? So if we have a negative perspective on what autism is based on history, based on our experience, based on what autism used to look like 20 or 30 years ago before we recognize some of the more subtle cases, oftentimes that's a reason why they're in denial, right? Or they knew another kid down the street who was autistic and they don't relate to them. Who knows, right? So sometimes that's kind of where to start and to figure out, what do you agree on? Maybe the diagnosis or the word for it isn't that important, but identifying the different things, the aspects that the person is struggling with or what's interfering in their lives is a way to start and say, it doesn't matter what we call it, but let's identify the things we have to work on. But that's so tricky, right? Because with adults, there's only so much that we can push.
And I want to add on to what you're saying, Lindsay, because her second question is about burnout, no longer wanting to attend therapy. This is why another reason for doing diagnosis early, because when your child is young, it's easier to get them to go to therapy. But as they age, their patience for participating in therapy dwindles. No matter whether they accept the diagnosis or not, it's just that they have a lot more in their life, and they start just being self-selective about what they want to do. And really at that point, they need to be involved in the choices of therapy if they get to an age where that's my opinion. I'm not a professional. I'll let Lindsey answer.
No, that's a great point.
That's been my experience, is that there have been things that my son has been willing to do as he's gotten older, but he has to be a part of that decision process. If I try to push him into something without him making the decision, it's not going to work. So, once they start being a teenager, you remember being a teenager and not wanting to do anything your parents wanted to do, and they're no different than you.
That's such a good point. I really appreciate that perspective. Yeah. I would also say, kind of along the same lines, to piggyback on what you're saying, is to also validate that experience for them. Maybe they had therapists who really didn't get them, right? Like maybe they really didn't feel heard, and maybe the therapists really weren't helpful. So, and again, that goes back to the diagnosis. And if you identify it, then finding a therapist who actually knows autism and can kind of meet them where they're at. But they might really feel burnt out. And I think starting also with validating that is a place to start, because then you're not butting heads. You're kind of joining, like, well, yeah, this has really been hard. It's been hard to find.
And I think that's one of the issues with ABA too, is that ABA isn't a single therapist dealing with you. It tends to be dozens of therapists over a long period of time. And there's likely to be someone that wasn't appropriate in some way, in terms of they didn't give positive feedback, they gave negative feedback. Some way of delivering wasn't compatible with your child. I'm not saying that they're doing something awful to your child, but it's just not compatible with how your child is wired. And everything can suffer because of that. So the older they get and the more experience they have with different kinds of therapy, the higher the likelihood that they'll do something that they are rejecting, and they can just holistically reject everything. So that's also.
Yeah, that is such a good point. I've also worked with teens or young adults who, let's say, they've been referred to a social skills group, and social skills groups can be wonderful. But if the composition of the group is not right, where they look around the room and they don't relate to other people in the room, they will also say, I'll never do social skills therapy again, right? Like, I'm not open to this. So you're right that those past experiences of not feeling like people get them, that can turn them off from therapy.
Yeah. So speaking of therapy, that was another set of questions we have. Okay, so there's a two-parter here. Someone gets a diagnosis. What do you recommend for therapy to the patients that come and see you?
Yeah, totally depends, right? And this is part of the individualized assessment. So this depends, like, are you a rocket scientist struggling with work and relationships? Are you someone who couldn't get through college because the executive functioning and the emotional interference, even though you're super smart, got in the way? Where are you in life? What are your goals, right? So totally depends. That said, some of the things that come up in recommendations are finding the right therapist. So finding someone who gets neurodiversity, who gets autism, who, if there's a comorbid diagnosis like anxiety or depression, has training in that too, right? So really encouraging a therapist who can help the person process their diagnosis, can process what it means to be neurodivergent. If the person feels like they've been masking their whole lives, I'm not going to recommend a social skills group, right? Because then they're going to feel like, oh my gosh, it's more people teaching me how to mask. If the person feels like, I've always wanted friends and I feel like I'm just watching a fishbowl and watching everyone else do it and I can't quite figure out how to get in, I'm going to recommend a social skills group for adults, right? So it's really, I really want to listen to the client and what they need. Sometimes we're recommending dating support because that's what they feel like they need. Sometimes it is more of the straightforward, like accommodations for college. Sometimes it's medication management. Maybe they've been treated for ADHD or anxiety, and having the autism diagnosis helps inform the psychiatrist about what medications they might respond to. We just started process groups at our clinic. This is another, I'll skip ahead. Where this is a little bit different than social skills groups. I've just been hearing from so many teens. And by the way, my caveat here is that I used to work with peers and I love social skills groups. I think there's a place for them. That said, I've had quite a few teens and adults kind of be like, don't send me to another social skills group. Like, like I've learned how to start a conversation, but something's getting in the way and I'm not necessarily doing it. And so we started these groups just listening to so many of our teens and adults who we were diagnosing, saying that they feel alone in this struggle, that they have social burnout, that they're masking, that it's so exhausting to have to explain themselves to other people, that they're having a hard time communicating within their family, that there's social conflict that's confusing and they don't understand what's wrong, that they want to figure out dating, they're struggling with sexual or gender identity, they're struggling with being able to manage day-to-day life with school, for example. So many things that go along with an autism diagnosis that they feel like they're struggling with. So we just started recommending this for some of our adults and teens. And I think I mentioned before, I'm on like week 3 with my teen girls, and it's been really fun because they're giving input to each other. They're realizing they're not the only ones going through, even if they're all different from each other, that they're not the only ones going through this. And so we're hoping I have a few girls in college who are kind of I have like these little chunks of lists, like girls from college. I have a few teen boys waiting. So once I get like 5 or 6 of each of these, that's when we'll do the next group. So that's a new thing that we're recommending. Does the regional center cover costs for assessment and therapy? I don't think so. Judy, do you have more experience with that? I'm just looking at the question that popped up.
I think they might. So I don't want to say no.
Well, maybe assessment and therapy within the regional center.
Within no, with therapy through regionals, they might. Let's just put it that way. First of all, there are some therapies, like if there's just a variety of issues you have to go through with them. Like they are not the first place to go. They're by definition the place of last resort. So they may say, well, you need to first go to your insurance or things like that, or you need to go through the school system. No, so there's that issue. But sometimes, you can negotiate and get things like therapy and assessment. You can get put on self-determination, and then you can choose how to spend your budget, and you can choose to do therapy or assessment. So I don't want to say no. I want to say it depends, and you should talk to them and talk to other people who might have gotten something and found out what was the magic word they used to get that service. So I don't want to.
Yeah. Yeah.
So the answer is it depends, and do your homework.
Yeah, that's great. I forgot to mention, so this is our little team. My husband did mention that it doesn't look very diverse.
All beautiful women. Like Charlie Angels.
He's like, at least it's not all men, but still. But her picture is not on here. We just added one more person who's a neuropsychologist, and she's wonderful because actually she started as a school psychologist, an educational psychologist. So in schools, really better understanding these different accommodations and qualifications and eligibility. And so I brought her on because sometimes we're doing an assessment and things come up like, well, actually, he didn't really learn to read till 3rd grade, or he's always struggled with math. And then we want to make sure we're getting the whole picture. So sometimes we'll add on testing. This is a new thing where we have a neuropsychologist on staff where autism doesn't just happen in a vacuum, right? But understanding the bigger context. So we've added her to the team. We need those magic words. Some magic words for insurance. I've had some families, and this is off the record, even though we're being recorded, but yep, you can hire an advocate. I know that as far as those super bills, I've had a few families who have said, look, our insurance gave us a list of people in network, and there is no one in network who specializes in autism and comorbidity or has expertise. They've used words like specializes or expertise to say, like, you're not really giving us an option as far as someone who's qualified to do this. And so we want coverage for someone else out of network to do it. So as far as therapy, because we do, there we go. We do, I haven't talked much about it, but we do individual therapy. 3 of us in the group provide therapy. And so I've had some families get more coverage that way. And I know some families are getting covered with assessment because we have a front desk coordinator, and I'll see the emails like, okay, I found out from insurance that they're going to reimburse a big chunk, so we're ready to go. So I think I really encourage, when you're going through this process, to have that conversation with insurance ahead of time, so you know what to expect. And yeah, if it's a matter of the school district, we've had some people have school district cover therapy. I don't know the ins and outs of how people get them to do that. I think they've exhausted other options at schools, but maybe having an advocate would help with that. So here's our little clinic. Here's some of the things we do. As I mentioned, sometimes we just meet with families like once or twice, like parents just want to kind of recalibrate where they're at with an older diagnosis, or get on the same page as each other as far as how to support their adult child. I have a couple like that right now where their child is in college, and trying to really get on the same page about expectations and how to best support her. So we try to support families in any way. We want to bring on a child psychiatrist at some point. Haven't done that yet. Yeah, I think other questions about assessment or things I haven't addressed?
Keeping we can go off of the chat now and just turn off your slides if you'd like, Lindsay, and see if anyone wants to raise their hand or ask any additional questions.